Hey everyone, we're here today to talk about obesity.
Well, I'm certainly happy to be here. And most people think of losing weight and managing weight as a do-it-yourself project.
Obesity is not entirely your fault.
Excess weight or excess body fat in itself is not a disease. So these assumptions that we make about people just based on their appearance and their size are so often wrong.
The skinny guy with a little paunch could have a larger risk associated with obesity.
Obesity is one of the most important and most common risk factors for a lot of different cancers.
Is it harder to lose weight or to keep it off?
Keeping it off. What policy are you going to have to reduce stress levels in the population? Those are the real drivers of the obesity epidemic. Someone has obesity because they're eating too much. The real question is, why are they eating too much? Because we live in this culture of grabbing bites. We're not sitting down to eat. You can fool your brain into thinking you've had a large meal when in fact you actually have had a very small meal.
Hey everyone, I'm Neha Dhupia and hello and welcome to a very special conversation. Today, we plan to have an unfiltered conversation about a rather filtered subject, about a subject that's very important to discuss in the right sense, and a subject that needs to be decoded to understand the truth. We're here today to talk about obesity. And to weigh in on this, I have someone very special, a name that is renowned and respected when it comes to talking about obesity. We have with us Dr. Professor Arya Sharma. Doc, welcome to this wonderful conversation. And why I call it wonderful is because I know that by the end of this conversation and on the other side, we'll be far more knowledgeable and far more sensitized to obesity.
Well, I'm certainly happy to be here and happy to meet you. And I'm sure we are going to have a long and hopefully enlightening conversation.
Yes,
about
because
this
we,
topic.
we have you. Now, it's a privilege to have you with us here today to decode obesity, to debunk myths and misconceptions around weight. Now, firstly and most importantly, we want to get to know you better. Now, as a doctor, one has multiple options. You can get into different aspects, different fields. Why did you choose obesity as a subject? What interested you? And how far has your research gone?
Yeah, I didn't actually start out with an interest in obesity. I started out as a doctor who actually looks after people who have kidney disease. But you don't have to be a doctor for long to recognize that a lot of the health problems that patients come to see you with, they have high blood pressure, they have diabetes, they have fatty liver disease. And you look at them and you know that the main cause, the main reason why these patients have these problems is because of excess weight. As I got more and more interested in this topic, trying to figure out why do people put on weight, what happens when you put on weight, how can you lose weight, and why is it so easy to lose weight but almost impossible to keep the weight off?
Yeah.
I started digging into the science of obesity, and I can tell you there's nothing more fascinating than the science of how the body regulates your body weight. There's a very complex science behind this. We've learned a lot about this. We're still learning about this, but that makes this probably today, if I'm honest, maybe the most exciting field of medicine to be working in. And I'm so happy that 20 years ago, I had this idea to move my entire practice into obesity medicine.
We want to know everything, but firstly and most importantly, let's start from the beginning as to when you have patients who walk into that room and when, you're discussing obesity with them, tell me what it's like to actually break it down to the patients, and what are the problems that you have when it comes to communication, and what's the mental health of all these patients when they walk in? Because, that somewhere they're scarred, somewhere, there is society that's not been very kind on them. And at the same time, that they're struggling and they've probably tried for many, many years before they've actually reached you.
Well, you're exactly right. By the time a patient walks into my clinic, they have probably tried a number of different diets. They've probably been frustrated. They've probably been doing this for a long time because, interestingly enough, most people think of losing weight and managing weight as a do-it-yourself project. When people get diagnosed with diabetes, who do they go to see? They go to see a doctor.
Mm-hmm.
When people get told they have high blood pressure, well, they go to see a doctor. When people have heart disease, they go to see a doctor. When people have a weight problem, the last person they're going to go to see is a doctor, because before they go to see a doctor, they're going to try their own diets. They're going to, listen to their neighbors, listen to their families, watch YouTube videos, maybe buy products off the internet, and they will have lost weight and they'll be extremely frustrated. They will feel like failures. They will feel like this is something that they have not been able to do. Everybody is shaming and blaming them. And then finally they decide, well, maybe I do have to see an expert, or I may have to see my doctor for this. And then they walk in. And right away, you can see that they have very mixed feelings when they come. There's a lot of hope. Now I'm meeting, the Dr. Sharma, and I'm hoping that he has a suggestion. But there's also this feeling of shame that really I don't, I'm almost ashamed to be here, because this should have been something that I should have been able to manage. And that, I believe, is one of the biggest misconceptions, that people think that their body weight is something that is their responsibility, that they should be able to manage, that they should be able to control. And if they can't, they feel embarrassed, they feel ashamed. And that is also what society tells them, that if you are living in a larger body, then somehow this is your fault. It must be your lifestyle. Maybe it's your mental health problems. Maybe it's because you eat junk food all the time. Maybe it's because you're sedentary. So all of these misconceptions are there in society. And of course, there's a lot of pressure, especially on women, to look good, to lose weight. And if you happen to be a bit chubbier, then people look down on you. There's no question about that.
Yeah. Doc, at some point, you did say that a lot of people think that it is, but obesity is not entirely your fault, and it can happen in many different ways. Now, can you debunk that myth for me? Because, a lot of us think that, hey, it's a lifestyle thing. Sometimes, people say, oh, it's genetic and it cannot be controlled. What are all these myths around obesity, and how can one control it from the very word go?
Well, one of the things that I've learned in, doing this for many years is not to judge my patient and not to make any assumptions. So let me give you a very specific example. Somebody walks through the door, say they're 100 kilos. Most people, when you look at this person, you say he's 100 kilos, maybe somebody should tell him to lose weight, because that cannot be healthy. Mm-hmm. Now, if I see someone with 100 kilos and I tell them, have you ever thought of losing weight? And the patient then tells me, well, you know what, doc? I actually had bariatric surgery 5 years ago. I used to be 140 kilos. Now I'm 100 kilos. I'm so happy I'm 100 kilos. You can imagine that there's not going to be a positive relationship here, right? Because why? Because I made assumptions. If I make assumptions about somebody, I look at them, they're 100 kilos. You know what? You should probably exercise. Then the patient says, doc, I'm glad you bring up the topic of exercise, because I just completed my 5K run and I was actually the first in my age group last week. Again, I made an assumption based on someone's appearance that they must not be physically active. In fact, actually, I'm amazed how physically active a lot of my patients actually are, right? If you make assumptions about people's diets, so I look at this guy, he's 100 kilos, and he's probably eating fast food all the time. And then, I ask him, so what do you eat? It turns out he's actually a gourmet chef, and he's actually written 6 cookbooks. And he probably has a diploma in healthy nutrition and healthy eating, and probably could teach me about healthy eating. So it's always these assumptions that we automatically jump to. And I find myself jumping to some of those assumptions when I see people. But I've learned in my profession, after dealing with patients, thousands of people that I've seen with obesity, I simply cannot make assumptions about people's motivation, about people's lifestyle, about people's physical fitness, about people, whether or not someone actually has a health problem because of their obesity, whether they're feeling happy, whether they're sad, whether they have depression, without actually having a conversation with that patient and doing the right test. And I think what society does is judges people on their appearance and on their sides and jumps to conclusions. For every person with obesity who is eating unhealthy, I will show you a skinny person who's eating as unhealthy.
Or unhealthier.
Or unhealthier. For every person with obesity who is sedentary, I will show you a skinny person who is as sedentary. For every person with obesity who has depression, I will show you a skinny person who has exactly the same depression. So these assumptions that we make about people just based on their appearance and their size are so often wrong and so often misconceived. And I think that is a huge problem. And that puts such a burden on people because you always constantly feel being judged.
Now, when it comes to tackling, obesity, when it comes to talking about the way, people perceive it, do you also have to go into that room and fight or undo all the mental, give me a better word for it, all the stigmas that the person would have had to fight, all the mental issues, feeling unattractive, not feeling included, not, just things like, I would say that, just examples like whether, if you have a slightly larger body, and if you're in the business that I am in, the guys with the larger bodies always get priority 2, 3. I'm saying even the simpler things in life. If you're on a WhatsApp group for paddle or pickleball, it's like the lighter people always get included first, and saying, hey, the heavier guys will not be able to move. But I have friends who are much heavier, and boy, oh boy, can they hit that ball. So tell me, but more importantly, what's the mental state? At what level do you have to fight it? At what level do these patients face it? And what can be done correctly, especially by society, to be a little more sensitized?
Well, I think the first thing we have to understand is that body shape and size is something that is extremely genetic. And what I mean by that is that the genes that you get from your parents have a huge influence on your shape, your size, the amount of body fat that you can develop, the amount of muscle that you have, whether you like sport, whether you like physical activity or not, even that is genetic. Whether your preference for foods, we understand, is highly genetic. And you see this in little babies.
Is that right? Like,
it's totally
preference
right.
for food is genetic.
Are
you saying taste buds are
absolutely.
genetic?
Absolutely. The field of behavioral genetics is one of the most exciting areas, trying to figure out. And you see, you have 2 kids.
I have 2 kids. They love chocolate. I don't.
And they're probably
it's not genetic, doc. The amount of chocolate my children can eat versus the amount of chocolate that I can eat. For every 1 piece of chocolate, they can eat a box of chocolate.
But I can tell you that there are kids who are not so fond of chocolate, and they'll find chocolate too sweet, and they don't like chocolate, but they prefer salty and savory, right?
Is there a study to make that switch?
Well, you can't make that switch. Why? Because that is something that is innate.
We need a different podcast for that.
You need a whole different podcast for that. What I'm trying to say is that there are a lot of things in your metabolism, in your shape, your size, that is highly genetic. And one of the first questions I always ask my patients is, okay, so tell me, which side of your family does this come from? Is this your mom's side or your dad's side? And patients will often tell me, oh, clearly it's on my mom's side, or clearly it's on my dad's side. And very often you'll have patients, it's actually on both sides.
Sorry to interrupt, but does that ever happen that you have both sides of the parents who don't have a weight problem?
Yes, absolutely.
And then suddenly you find, someone who has a weight problem. So again, understanding obesity as a disease, how do you deal with that?
Well, absolutely. And the other question I ask my patients, I said, if I bring your whole extended family together and we do a family photo, would you stand out on that photo because of your size? And sometimes the answer is no, I would fit right in. Everybody in my family? Or they would say, oh, I would stand out. I would be the only person in this entire extended family who is large. And that, interestingly, and a lot of people don't get this, can also be genetic. I don't want to get into this too scientific here, but we call those recessive traits, which means that you have to get the gene from both sides. And when you get both, you end up having obesity, but your parents will not. Why? Because your mom only has one of those genes and your dad only has one. So they're perfectly normal weight. You're the unfortunate guy who got the obesity gene from both sides, and so now you're the only one in that family who actually has the problem.
So is that
is also genetic?
But which still means that it is a disease, and there's a way of tackling it, right?
Well, the first thing, obesity becomes a disease when it starts causing health problems. Excess weight or excess body fat in itself is not a disease. In fact, actually, it turns out that body fat is a fantastic tissue, because the job of body fat is to take up calories, store calories for times where you don't need them. And the ability to actually eat more than you need and take those extra calories that you don't need and put them somewhere where they're going to be safe. And so fat tissue is actually a very useful tissue and is a great tissue to have. And without fat tissue, or the ability to have fat tissue, we wouldn't even be alive. But there are different types of fat tissues.
Oh, okay.
To make things really simple, you can think of there being 2 types of fat tissue in your body. There's the one which is the fat that's directly under your skin, right? So when you pinch your skin, and there's some fat in there. That is, we can call it skin fat, okay? That is actually the good fat. That fat does not cause health problems generally. It does when it gets too much, and then it's the pure weight of that fat that can actually cause problems. But actually, it's not a risk factor for diabetes. People who have a lot of skin fat don't necessarily get high blood pressure. They don't get a lot of these health problems that we normally associate with this. But then there's a different type of fat, and this is what we call the internal fat. This is fat that is not underneath your skin, but it's fat that's inside your body. It's around your various organs. It's inside the tummy. It's around your heart. It's around your kidneys. And there's fat over there. And that fat, when it gets too much, actually starts causing all these problems. So it's not the total amount of body fat that you have that causes diabetes, but it is having too much of that fat inside your body that's causing diabetes. And that's why you actually see a lot of people, they can be very big, they have a lot of body fat, they're large, and you look at them, oh, this guy really has obesity. It turns out their blood sugars are normal, they don't have diabetes, they don't have blood pressure, they don't have any of these issues. Why? Because they don't have fat inside their body. All their fat is underneath their skin. Now, you might not like the appearance, and it might be a cosmetic issue, maybe it's an aesthetic issue, but it's not a health issue. In fact, especially in women, if you had large hips and large thighs, you may not like them, but those large hips and large thighs are actually protecting you and reducing your risk of getting diabetes.
How's that?
Because it's the good fat. Versus, think of your skinny South Asian Indian male, thin arms, thin legs, looks completely skinny, and then you see them from the side and there's a small bulge in the belly.
Yeah.
That fat is far more dangerous because that fat is inside the belly and is causing an increased risk for diabetes, fatty liver disease, high blood pressure, and all the metabolic problems. Which of these two actually needs to go to see a doctor? Not the large people, not the large person
with guy with the little
the skinny guy with the little belly. He's the guy who actually has obesity. He's the guy who actually needs to see the doctor. He's the person whose health will improve. If that guy only loses 2 kilos, his diabetes gets better, his blood pressure gets better, all the health problems he has goes away. But he would never think of himself as having obesity. He will never go to see an obesity doctor. Why? Because he's skinny. The people who will come to see me are the ones with the large thighs, the large hips, who desperately want to lose weight. I do their blood work. I look at their diabetes. They're healthy people. They just happen to have large bodies, which they're unhappy with. What they're unhappy with because of societal pressure, because we live in this culture of thinness where everybody wants to be thin, and where people, and I can understand why they're desperate to lose weight, because I know that when they go out on the street, they are being judged negatively because of their shape and size, even though they're perfectly healthy. In fact, they're probably more healthier than me, right? So this is the complexity that unfortunately, when we talk about obesity, we are always mixing the aesthetic side of the cultural side to the actual medical side of things. Yeah. And they're not always the same. And so the reason that I say, if you are concerned about your size of your body, go and see a doctor, because only a doctor can tell you whether you're healthy or not. Because you have to do tests, and I have to take a good history, I have to do a physical exam, I have to do lab tests. And then I can tell you whether or not your weight, your body fat is actually a health problem, or it just happens to be the size of your body that you've got. And people, even skinny people are not often happy with their bodies. So, but that's a whole different topic.
It's a whole different topic.
With obesity.
Yeah, appearances, obesity, body fat, everything, and
body shape, body size,
and the kind of diseases. So, firstly and most importantly, obesity has got nothing to do with the dress size you're wearing. So we need to underline that. Now, I just want to know that when it comes to obesity, what are the multiple health issues or health scares that you could be living with and you're unaware of?
So, unfortunately, excess body weight, excess body fat, especially if it is the internal body fat, the fat around your organs, can lead to a lot of health problems. In fact, there are more than 200 health problems that can be either directly related to excess body fat or can be made worse because of excess body fat. The most common ones we talk about is diabetes. We talk about high blood pressure. We talk about people who have fatty liver disease. But we can also talk about things like fertility. Mm-hmm. We can talk about polycystic ovary syndrome. We can talk about sleep apnea. We can talk about gout. We can talk about gallbladder stones. We can talk about like I said, there's 200 different conditions.
Yeah.
The one that we don't talk about so much, although actually there's a lot of evidence for that, is actually cancer. Obesity is one of the most important and most common risk factors for a lot of different cancers. When we think of breast cancer, when we think of endometrial cancer, when we think of liver cancer, perhaps the most important risk factor that we have in the population is actually obesity. Nobody ever talks about that. And interestingly, we have a lot of data coming from bariatric surgical studies where patients have gone for bariatric surgery.
And that's when
their risk for cancer after having had bariatric surgery goes down to a level that is completely, it's not that they don't get cancer, but it is markedly reduced. So we know that not only that obesity can drive cancer, but that losing weight and losing weight in a way that you can keep it off, and we'll get to that in a minute.
Yeah, that was going to be, that was exactly what my next question was.
Very remarkably and very dramatically reduces your risk for cancer. It reduces your risk for heart disease. It reduces your risk for all of these complications. And that's why it's a medical problem. I'm a medical doctor. Getting people to understand the difference between living in a large body that you're not happy with for aesthetic reasons versus living in a body where your excess body fat is actually leading to a health problem that you're probably going to have to deal with and which will probably get worse over time. That is often the challenge, even in my communication with patients, getting my patients to understand that I'm a medical doctor. I care about your health. I don't care about your size. I don't care about your shape. I don't care about your appearance. I want to know, are you living in a healthy body or a sick body?
I may have a different opinion on this, that somewhere, if not always, the appearance is important. I know that you're not getting into that, but a large part or a little part of the appearance is also a signal that, hey, something could be wrong. So
Absolutely.
one needs to address that basis on appearance. And people who are actually taking measures because they're not happy with a particular size, or if they think that, yes, they are getting large, and doing something about it may not be such a bad thing. Now, when you do something about it, is it harder to lose weight or to keep it off? Now, which part of this is harder to tackle?
Keeping it off. And I can say that because losing weight, I mean, everybody I've seen, in fact, almost everybody you meet has at some point or the other lost weight. And there's many ways to lose weight, because losing weight is the easy part. I mean, there's, every diet works when you do it. You can do keto, you can do intermittent fasting, you can go low protein, you can go low fat, you can go high protein, you can do all of those, right? You lose weight. The problem is not losing weight. The problem is keeping the weight off, because every single study that has been done on people who have tried to lose weight, and they lose weight, and you look at them after 2 or 3 years, they're back to where they started. In fact, a lot of patients will actually their weight will be even higher than where they started, right? So the challenge in obesity management is not how do I get my patient to lose weight. The biggest challenge, in fact, the only challenge in obesity management, is how do I get my patient to keep the weight off? And that is really where the science of obesity comes in, because we have to fundamentally understand that our bodies will do what they can to protect our weight. That's how we survive.
Oh my God, I'm going to underline that again. There's just so much, and it's baffling the amount of information I'm getting today. But our bodies will do whatever they can to keep the weight on, is what you said.
To keep the weight on, right? So the minute you go into...
How unfair is that?
Well,
hey, body, keep it on.
Well, that's the only reason we're here, because our bodies have the ability to gain weight when there's food around, store the food for when there's no food around. But then when you enter this period where there's less food, your body says, well, now we can start using some of those reserves, but we want to be very careful about using them. So we're going to reduce the amount of energy we are spending, which means your metabolic rate, which means the number of calories that you burn actually goes down. And what also happens is your appetite actually increases. And this is a very complex biology that happens, because your body is trying to defend its body weight and is trying to prevent you from losing weight. And if you force it to lose weight, it will actually work against you. And there's a very powerful biology that does this. And if you want to put it very simply, the biology is very complex. But the result of that biology is that eventually you're going to start craving things. You're going to start getting hunger. It'll come to the point where you will sleepwalk to the refrigerator, because your body is desperately trying to find calories because you're starving. That's a normal response. At the same time, your body has also turning down its metabolism and saying, okay, if there's not enough calories coming in, well, then I'm not going to burn those calories, which is why we can see that in every diet that people do, when you measure the amount of calories they're burning after they lose weight, it's almost an entire meal that they no longer need, because their body has actually reduced the number of calories that they need. And so your body is going to resist weight loss, which is why when you start off on a diet, it doesn't matter what diet you do, the first few weeks go great. You start losing weight and you're happy, and then you will continue doing what you're doing, and the rate of weight loss will slow down and slow down and slow down. And then 3 months, 4 months into your diet, you're still on the same diet. You're still not eating what you used to eat, but you're no longer losing weight.
So what
And
is
that's
the
when you
right
hit the
thing to
plateau.
do?
And that's when you hit the plateau.
So then, yes, the big word, the plateau.
The plateau. And everybody hits the plateau. And then and at the time you've hit the plateau, that is the time when you are the most vulnerable for weight regain, because now your body is going to try to get all that weight that you've lost. It's going to try to get that back. And
Why?
Because that's how bodies work. The same will happen to your dog when you put it on a diet. The same will happen to your cat when you put it on a diet. The same will happen to your goldfish when you put it on a diet.
So don't go on a diet, or go on a diet, or do the right thing, or go on a specific kind of diet.
Let's talk about why would you do obesity treatment. So the problem is really that your body is going to fight you on this. It's going to fight you every inch of the way. And in the end, the body is going to win. Right? So when you look at people who have successfully lost large amounts of weight, and not after pregnancy, we'll talk about pregnancy in a minute if you want to. But
yes, I'd love that.
Okay, but other than pregnancy, every other weight gain that people experience in the course of their life, it's usually the highest weight that they've achieved, which becomes the weight that their body wants to be at, if I can put that. And that is always the weight that your body is going to want to go back to. Any restrictive diet, you can do it for 2 months, you can do it for 3 months, you can do it for 6 months, but nobody, or very, very few people, manage to live like that for the rest of their life. So people ask me, does keto work? Yeah, keto works. But do you want to live on keto for the rest of your life? Because we are talking the rest of your life means the next 40 years you're going to be only keto. The minute you come off keto, guess what happens? That weight's coming right back, because that's how bodies work. And that is the challenge in obesity management. It's not how do I lose weight, it's how do I keep the weight off.
Yeah.
And that's where we now talk about medical treatments. And this is why people have so much more success with medical treatments.
So the larger problem that we're dealing with right now is not weight loss. We're actually dealing with weight off.
Maintenance of weight loss.
Maintenance.
Or weight loss maintenance.
Yeah, right? But I mean, with the number of options that you give and the way you describe the human body, and I always feel like it's a losing battle till you don't have a finite cure, which I feel somewhere lies in treatments, in medication, which I have very little knowledge about, and I want to come to that. But at some point, you did say postpartum weight, which is soon after you have babies or when you're pregnant, and the weight that you gain. Now, you did mention that it's the maximum weight your body has seen or been in is its kind of safe or comfort zone that it always wants to go back to.
Let me make you happy and give you the good news.
Yes.
I said the body will defend the highest body weight that you've ever achieved.
Mm-hmm.
That excludes the highest weight you've achieved in pregnancy.
Okay.
Because pregnancy is actually the only state where you can gain a very significant amount of weight without the body then defending that weight after pregnancy, which is why the normal course of pregnancy, I'm not saying the most common course of pregnancy, but the normal course of pregnancy is you gain weight during pregnancy. And within the first 6 to 12 months after pregnancy, most of that weight will come off, especially if you're breastfeeding.
Yeah.
And it will come out with, yes, you may have to work a little bit on it, but it'll come off relatively, I would say, less effort than if you're trying to lose 22 kilos without the pregnancy, okay?
There was a lot of effort.
There is effort, but it's possible. And the reason that I said that is normal, but is not the most common one, because a lot of women do actually find that once they've had their pregnancy, that they find it difficult to lose weight, and then sometimes they find that the weight is very hard to get off. And there's a lot of reasons. We call that, actually, the technical term is postpartum weight retention, and what that means is not losing the weight that you put on during pregnancy, and that can then become a chronic problem, lifelong problem. And there's lots of reasons for that. We've got postpartum depression. You said the relationship enders. You're not getting enough sleep. There's a high stress level. There's all these things that happen in a woman's life after pregnancy that can make it very difficult to actually lose weight. But if that weight does not come off within the first 6 to 12 months after pregnancy, it's probably going to be around for a long time, and then it kind of leads to that set point. And that's why everybody tells you the recommendation is within 6 to 12 months of having delivered your child, you should be able to get back to the weight that you had pretty much before.
Now, coming back to weight gain, it's got nothing to do, which you've mentioned, and I'm just going to say this again, it's got nothing to do with willpower. So before we actually reach out to people, or we attack people, or we just put them in a box saying that, hey, this person doesn't have the willpower to lose weight, It's beyond that, right, Doc?
Well, if you look at it, so I often get asked this question. What is driving this obesity epidemic? Like, why is everybody getting bigger? And I said, there's probably three major reasons. The first one is high stress levels. We are constantly in a state of doing things. Everybody's busy and high stress. Now, what high stress levels do is actually they increase the level of hormones in your body that make it much easier to gain weight and much more difficult to lose weight. So simply being in a state of stress, and you can do this beautifully in animal experiments. If you take animal experiments, you lock them up, you tease them, you make them uncomfortable, they all gain weight. And the reason to do that is because mental stress will actually cause weight gain. Now, there are some people who, when they get stressed or they stop eating, they lose their appetite.
Yeah.
That happens. But the majority of people, when they actually get into stressful situations, they actually start gaining weight. So stress is an important one. The second one, you see, yes, we live in an environment where both culturally and also we are constantly surrounded by food. But the real reason for eating fast food is not the food, it's the fast. It's a time problem. See, eating healthy actually requires a lot of time and it requires mindfulness. So if you look at how long should a meal take, it should take at least 20 to 30 minutes. And while you're eating, you should be focusing on the food. You should be mentally there. You should be mindful of what you're doing. You should be chewing every bite. You should be savoring every bite. You should be taking your time. Well, that's 20 to 30 minutes. And in fact, our biology is designed in such a way that only after 20 minutes or so of starting a meal does your brain actually realize that you've eaten. So that's when the sense of fullness sets in. Now, I can do a lot of damage in 20 minutes.
Oh, yeah. So can I.
Especially if I'm not paying attention, I'm being distracted because I'm driving my car or I'm listening to somebody or I'm screaming at the kids or I'm sitting at my work or I'm on a telephone call or I'm doing something else, because we live in this culture of grabbing bites. We're not sitting down to eat. Why do people take a smoothie? Well, they could have everything they put in the smoothie because it would take 20 minutes to chew that stuff. So now I put it in a blender and then I can drink it and I'm done. Right? So it's a time problem. It's lack of time that's driving this. If you say, I want to eat healthy the way actually we were supposed to eat, that's 20 minutes a meal, 3 meals a day. That's 60 minutes of eating where you do nothing other than eat. Nobody has 60 minutes to eat. Right? So this becomes a time problem. Now, that is the eating part. Now, if we say healthy food should be prepared fresh in the kitchen. Now, in India, you've got people to do that for you. In most places, you don't, which means now you're going to spend 2 hours in the kitchen every day preparing the healthy food you're supposed to eat in the 60 minutes where you have to sit down and eat and do nothing else while eating. We're talking about what? 2 hours of eating or time of your daily time attributed to being healthy. That's a lot of time. So we try shortcuts and then we do shakes and then we do, blenders and we do smoothies and we do all that. But why are we doing all of that? We're doing all of that because we're not taking the time to eat healthy. So it's a time problem. So if it's a stress problem, it's a time problem. What's the third problem? The third problem is lack of sleep. We are not sleeping.
I was close.
We are not sleeping enough. And everybody can tell you
what is enough? What is enough sleep?
There's a range where it is enough. But to get the amount of restorative sleep, it's not how much time do you think you're in bed or you're sleeping. Waking up in the morning feeling refreshed and saying, yes, I can grab the new day. I've had as much sleep as, and then you can go for hours mentally, you're accurate, and you're not dependent on coffee to survive, right? That's when you've actually had enough sleep, right? Most of us don't have that. We get up early, much earlier than we would normally get up. Some of us have to set alarms. You need that coffee to actually get going. And then by the time you hit noon, and then you just keep going. I mean, there used to be a time where people would take afternoon naps, and afternoon naps is the healthiest thing you can probably do. Get an hour of sleep or a half an hour of sleep after lunch. Just lie down, call it the siesta. Nobody does that anymore. Why? Because we don't have time. So now we're getting in the time, lack of sleep plus stress. Lack of time, lack of sleep causes the stress. It's a big part of the stress problem. So you're in this vicious cycle where you've got high stress, you've got no time. Now you don't have time to sleep. People say, well, I have to exercise. How do I exercise? How do I make time for that? I get up an hour earlier. Well, now you're sleep depriving yourself again, because that only works if you go to bed an hour earlier. Yeah. And so you keep on in this cycle of high stress, no time, not enough sleep. And as a result of that, you end up eating more than you actually should, and you have less control over your food intake, which then leads to the cycle of obesity, right? So it's not the food environment. The food environment just makes it possible. Obviously, if there's no food, then there's no food, right? But it's because I'm in this constant state of anxiety, depression, worrying about things, stress, things to do. My mind is somewhere else. I'm not focusing on the food. I'm not mindful. I don't have the time to prepare meals from scratch that are healthy, where I start with fresh ingredients that I brought this morning from the farmer's market. Nobody has time for that kind of stuff. So those are the actual drivers of the obesity epidemic, because that is happening in societies across the world. And so it doesn't matter where you go in the world, you have the same problems, where people have, where people don't have enough time, where people are in constant stress, where people are working 24/7 because they're getting emails from their boss at, at 1 a.m. That they feel they have to respond to. And people are not sleeping enough. Why? Because, well, you spend the evenings, you worked all day, now you come home in the evening, then you do what you do in the evening, you go to bed at 12 o'clock, you have to get up at 6. Well, that's 6 hours of sleep. Now, let's add to that the fact that for a lot of people who actually have obesity, who might even have a problem called sleep apnea, which means that when they are sleeping, they don't really go into deep sleep, because when they go into deep sleep, actually they stop breathing, they find it difficult to breathe. So they're always, so yes, it looks like they're sleeping for 6 or 7 or 8 hours even, but they're not actually getting restorative sleep. It means they wake up in the morning still feeling tired, like they haven't actually slept enough. Those are the real drivers of the obesity epidemic. And that is why on the prevention side, we are having such a hard time preventing it, because what policy are you going to have to reduce stress levels in the population? What policies can you have that is going to give people more time? What policies can you have that is going to tell people you need to sleep more, right? And so that is where I can control the food environment. I can tax the food, I can ban food, I can put labels on them, I can warn people you should be eating, I can educate people. But that's not actually addressing the root problem, the root cause of the problem, why people eat too much, which is largely high stress levels, lack of time, people rushing around, not having enough sleep, and obviously the food pushers, right? I mean, we're constantly.
Yeah, but I feel like then, with the way you've described it in the chain, food is actually number 5.
Food is a symptom. Eating too much is a see, the way I look at it in a patient is always, when you say, why does this person have a weight problem? And you tell me, well, because he eats too much. That's like saying, if I were to ask you, why does this patient have depression? And you told me, well, he has depression because he's not happy. Well, you've just described the situation, but you've not told me why he has depression.
Yeah.
No, you've just described that he's unhappy. So when you say someone has obesity because they're eating too much, the real question is, why are they eating too much?
So what you're trying to say is that, to sum it up, that these complications are either mechanical, metabolic, or mental.
Well, those are the complications. I mean, if you look at how can excess body weight or excess body fat, if it's the wrong type of body fat, affect your health? Well, yes, you can have medical issues. We've talked about it. We can say that people have diabetes, they have high blood pressure, they have fatty liver disease, they have polycystic ovary syndrome, fertility issues, all those issues. Those are the metabolic problems. Cancer, that's a metabolic problem. Then we say excess weight can also lead to mechanical problems. By mechanical problems, we mean these are problems that actually result just from the fact that you're living in a large body. These are weight-dependent problems. So now you might get osteoarthritis, your knees might start hurting, your ankles might start hurting, your feet might start hurting. That's just because, well, your joints are carrying that weight. So that's a mechanical problem. You might have a lot of weight around your neck that's causing sleep apnea, that's obstructing your breathing when you sleep. Those are mechanical problems. And then we have the mental health problems, and that's what we've also talked about. That is when you're depressed about how you look, when you have body image issues, when you have anxiety about this. It goes to the point that people are not leaving their homes because they're so embarrassed about their appearance that they actually develop social anxiety disorder, right? These are not the people. And then they meet someone who says, no, you should go to a gym. The last place on the planet that these people will ever go to is a gym.
Yeah.
Why? Because they're exposing themselves with their bodies to a whole bunch of people who
look very different from them.
Who look very different, who are very, very judgmental. And a lot of people have told me, well, they don't go to a gym for a simple reason, because there's a mirror. Just having a mirror hanging there will stop people from going to a gym, because you don't want to watch yourself, because that just brings you down.
Yeah, and then it's sad because it's also correlated, right? Because when we discuss the 3 M's, which is mechanical, metabolic, and mental, it could start either way. One could have all 3, and one could have just one aspect of it.
Absolutely.
But the point is that one needs to address it. And the truth is that the importance of seeing a doctor when needed, uncovering myths and the truth about weight and obesity and improving our understanding and how we go about the subject is extremely important. Now, on the good news.
Okay.
Are there any treatments?
I can tell you the most frustrated thing about having been an obesity doctor for the last 20 years is that I've almost had no treatments to offer my patients. Mm-hmm. Yes, I can put them on diets and they follow it and they lose weight, but we have had very little success in medicine in getting people to keep the weight off. The only people who have actually been able to really get long-term weight loss have been the bariatric surgeons. Now, I'm not a surgeon, and I've always envied my colleagues in bariatric surgery because the results of bariatric surgery for most patients, not for everybody, for most patients, are actually such that people can lose 20, 30, 40 kilos and keep them off for 20, 30, 40 years. In medicine, we have never been able to do that, right? Because people will lose the 30, 40 kilos, and then after 2 years, they put the 30, 40 kilos back on. Now, interestingly, in the last 10, 15 years, the science of why the surgeons are having so much success and why we as medical doctors have not been having success, the answer is pretty simple. What we now know is that every time you have a meal, your gut actually releases hormones that will tell your brain that you've had a big meal.
Yeah.
It takes about 10, 15 minutes, but after having a big meal, you start feeling full. Now, that feeling of fullness is actually a result of these hormones that are being released by your gut. Now that we know which hormones those are, we can actually make those hormones. And the new medications that you're hearing about are actually exactly these hormones. Now they've made a medication out of that, but it's the same hormone.
But then aren't you depriving your body of essential nutrients?
No, because you're still eating, right? You can still eat, but what patients who take this medication will tell you is, I'm eating much smaller meals, but because even with small meals, I'm already starting to feel full.
And what you need is just a small meal?
And what you need is just a small meal, but this is where it gets tricky, right? The quality of the small meal has to be good.
Yes.
Right? So as people are eating less, but that's true for every diet. Anytime you reduce the amount of food that you're eating, the quality of the food has to be better. Right?
So what these treatments are actually doing, and what I understand, and I could be wrong, is that they're actually cutting down your craving and your ability to eat excess.
They are fooling your mind into thinking that you have just had a large meal when in fact you've actually only had a very small meal. So you can think of this, and this is exactly what patients will actually tell you. So there's a few things that happen when people take these medications, and you'll hear the exact same story from someone who's had bariatric surgery. Doctor, I'm no longer thinking of food all the time. Mm-hmm. Like food is no longer my main priority. Because people, especially people who are struggling with it, they're thinking of food all the time. You know what, doctor? For the first time in my life, there were actually 4 hours in which there was not a single thought about food. It didn't even cross my mind, right? Why? Because I wasn't thinking of food, right? I was full. And what patients will also tell you is, see, it doesn't change your sense of taste, but the food tastes as pleasant as before, but you just need less of it. And that is actually what these medications do, because through the science of how the body actually regulates appetite, we understand so much about the science now that we can actually mimic through these medications. We can fool your brain into thinking you've had a large meal when in fact you actually have had a very small meal, which is hopefully a healthy meal. And that is why patients can do this. Now, the downside of this, so the medications work. We've got all the studies now showing about safety. We know that this, yes, there are some.
Have they been around long enough?
Oh yeah, they've been around. See, the principle of these medications has been used for treating people with diabetes for more than 15 years. And there are literally millions of people who have been taking these type of medications for their diabetes for long.
For their diabetes, by that you mean to control their sugar,
the
so
blood
that
sugars.
The body fat is also controlled at the same time, or cravings are controlled for the blood sugar to be in control.
When these medications were first developed, this is 20 years ago, and they've been used for the last 15 years for treating diabetes, that has always been the focus of these medications. And it took a while to actually realize that people, not only is their diabetes getting better, they're also losing weight. And then the science came in and said, now why are these people losing weight? Right? This was not a weight loss medication, but they are losing weight. And then you talk to these people, and then you start understanding the science that these medications are the exact same medication, are the exact same hormones that your body makes after a meal that signals satiety to your brain. And that's why these medications are actually working. Now, the downside of medications, of course, is
Before we get to the downside, I have a
Yeah.
question. I'm going to interrupt. Now, are the medications that are there in the market for diabetes recommended for weight loss, or are they weight loss medications in isolation?
Okay.
Because there are two different sets of things, and people
Yeah.
shouldn't mix that up.
Yeah. So there's a lot of confusion there.
Yeah.
Because it's the exact same hormone. When I use this hormone at a low dose, I use it for diabetes. When I use it at a higher dose, I get more of the appetite reducing effect. So as low, which is why it's the exact same hormone, but the doses are different. So sometimes you hear that, this medication is there in two different brand names. One brand is for, one brand name is for diabetes, and the other brand name is for obesity.
But it has the same.
It's the exact same molecule, except that the dose that we use to treating obesity of that exact same medication is much higher when we're trying to treat obesity, because we need more of this hormone so that it actually gets into the brain and actually works at the centers in the brain that regulate appetite.
And that's why going to the expert is important.
Right. So it's now some people are very sensitive to these medications, and so they can actually get away with the same low dose, right? So not everybody has to take that high dose to get the result. And even at a low dose, a lot of patients are already finding that, actually, you know what, this is enough for me. But if it's not enough, then, we use a higher dose. A lot of that depends on how well the patient tolerates this medication, because remember, we're talking about hormones. We're talking about a hormone treatment. We're talking about, a hormone that is going to make you feel full. Now, if you take this medication and you have a large meal, obviously that sense of fullness can become nausea. And in some cases, that sense of fullness can lead even to vomiting, and that's a side effect. But that's what these medications do. And so when you start patients on these medications, you start with normally, actually, in fact, that's how we do it. You will start with a very low dose. You may get some fullness, you may get some nausea. That's fine. Your body is going to get used to those levels. It'll go away. Then we increase the dose, and so it can sometimes take you up to 3 months to actually get to the dose that we are trying to get. But that has to be very carefully managed. You have to manage it with patients, which is why you need to see a doctor, right? This is not something you can go to the pharmacy, give me this medication, then you try it yourself, and then you'll probably get sick, and it's not going to work for you.
But is this lifelong?
This is really why we talk about obesity as a chronic disease, and not as a problem that I can fix with a 3-month course, 6-month course, 12-month course, because your body, if you successfully lose weight, will always try to put the weight back on, right? And that means that you will have to continue with these medications, which a lot of people say, but then they don't work. No, but we continue with lifelong medications for every other disease. We do this for diabetes, we do it for hypertension, we do it for heart disease, we do it for cholesterol. Now we can do it for obesity also, because these medications, we know that they're safe. We know that they're highly effective. And you could almost say it's a natural treatment, because we're actually using a natural product, which is basically the same hormone that your gut makes after every meal.
And you can have this medication when you have other problems as well, or that?
Absolutely. I mean, there are contraindications. Like for every medication, you probably shouldn't be using it while you're pregnant.
Yeah.
You probably shouldn't be using it while you're breastfeeding.
Yeah.
There are certain people who may have had problems with they might have had other underlying diseases where you would say maybe this is not the right medication for you, which again is why you need to see a doctor.
Yeah.
Because before you start these medications, you want to make sure that this is the right patient for this medication. And as I said, you have to be using them carefully. And this is not a do-it-yourself program. But they certainly work, which is why all the excitement is there. And the reason everybody's so excited about this is because now we are, for the first time, entering a completely new era in our ability to medically treat obesity, for which so far the only really long-term effective treatment has been surgery. And I'm not here trying to put the surgeons out of business, but as a medical doctor who's not a surgeon, I am more than grateful that we now have these tools to help our patients who are desperately needing treatments, because there has been no treatment. But there seems to be a lot of stigma around this idea that taking a medication for obesity somehow is taking a shortcut or is cheating.
Yeah.
And this is really something where we have to educate people and saying that no, taking a medication for obesity is like taking a medication for diabetes or taking a medication for blood pressure. If you take a medication to lower your cholesterol, well, that's not cheating. No, that's a treatment for high cholesterol.
And I would imagine it being difficult as is, because even along with taking the medication, there must be multiple other restrictions that come with it.
Well, there always are. I mean, you will tell every patient, try to eat as healthy as you can, try to be as active as you can, try to work on your stress levels, try to work on, life work balance if that's even possible, try to get enough sleep. I mean, all of these health behaviors are things that you will tell every patient, including patients living with obesity. But what these medications or this hormone treatment or semaglutide in this case actually helps patients do is lose weight without your body responding by making you hungry all the time, by creating all kinds of cravings, and by making it so difficult for you to keep the weight off. That's what these medications ultimately do.
So when is the right time to actually take the medication? When you feel when you've reached a plateau, what is the right time to take this medication? I mean, what is the right time to take this treatment?
Well, like in any chronic disease, the decision, when do you start with a medication and when do you take the medication, which medication do you take, what dose of the medication do you take? I mean, those are things that, the doctor has to decide based on what is the problem you're trying to solve, what is the health problem, how much weight are we talking about, what are the complications, do you have diabetes? I mean, this is why this becomes, a very personal relationship to your doctor, where you have to make the decision on saying, what is the risk of treatment, which is quite low, but what is the risk of not treating, which might be much higher? And it is that risk benefit discussion that you have to have, and that is going to be different for every patient.
And then speaking of risk, what is the flip side, or what is the downside?
Yeah,
Any negatives?
Well, the biggest negative, perhaps, apart from the fact that a lot of people feel like they're taking a shortcut, so let's forget about that psychological bit of it. The actual physical negatives of taking these medications or taking this hormone is that it increases your sense of satiety, which means that that feeling of fullness, if it becomes too much, will become nausea.
Yeah.
And in fact, that nausea can then proceed to actual vomiting, which of course is unpleasant. Now, you can avoid all of that by educating the patient, by starting with a very small dose, by making sure that when the patient takes these medications, that they're not eating large quantities like they used to before, which, by the way, patients find a lot easier now because they're not starving. And so those are the main issues that we have starting the patient on the medication. When patients get pregnant, obviously you want to stop the medication. But otherwise, the plan is to keep the medication on because, as I said, medications only work when you take them. So if you're going to stop the medication, suddenly the hunger comes back, the appetite comes back, the cravings come back, and you're going to eat more, and very quickly you're going to go back where you started.
And right? Is this a lifelong dose?
For most patients, it probably will be, right? Mm-hmm. This does not mean that there will be some patients, they can probably reduce the dose. Maybe they can get away with less dose. But what the research shows, and what I expect actually, is that most patients, when they come off these medications, are going to put the weight back on, because that's how bodies work. And we talked about this, that your body is going to try to defend its body weight. These medications are fooling your body into thinking that you're still 100 kilos when in fact you're now only 80 kilos.
Yeah.
Right? But the minute I take away the medication, your body suddenly realizes, oh, now I'm 80 kilos, so I got to get back to 100. And then that's exactly what the body is going to do. Yeah. It's going to take you back to 100. And that's what, but as long as I continue taking the medication, my body continues thinking I'm 100 kilos when in fact I'm 80.
Oof. This has been absolutely educating. It's been enlightening. It's been wonderful talking to you. Thank you so much for helping us, understand the importance of uncovering myths and the truth about weight and obesity, and improving our understanding and how we can go about this subject. That was Dr. Professor Arya Sharma. This is me, Neha Dhupia, and I'm signing off. We were in conversation talking about everything beyond the scale.